Is it sharing? Are we sharing?
Yeah, it says
Yes.
sharing, but it's just, oh, there we go. We can see it now.
Basic neural assessment. I'm going to go back a little bit. So I want you to remember a couple of things. Cranial nerves and their functions in order is a free response question. So I give that to you right the first day, the first minute of this lecture.
You said,
And I know you had to memorize that in
Yeah.
anatomy and physiology, but it's just a refresher for you. I spoke about basic neuro assessments. Like I said, you should be doing this in all of your assessments. You should be doing this, just the basic, you know, you're going in, you're checking their mental status. You do that like right when you walk into a patient's room. Ocular changes, if something's different, motor sensory functions, you know, when you say, can you grab my hand, push forward, push backward, that all of that is part of your basic neuro assessment. If something is not right or different, you're going to notice it. But this is a screen that I want you to look at, the third one down. Now, this might be for a patient, their baseline. It could have been an eye accident or a neuro accident that happened in the past, and this is how their baseline is. So you want to make sure, like when you get report, you find out, because if there is a change in status and a pupil is dilated or blown, so to speak, or paralyzed, you do want to know this. You want to know in that moment if there is an emergent situation going on. Pinpoint, it says pons damage or drugs. Bilateral dilated, it could be fixed, it could be meds that they got, it could be light, you know, a change in the light. But normal pupils that react normally, you use your pen light, you check, pupils are reactive, they're the same size, they follow you, that type of thing. So you just want to make sure. We had an instance where a nurse sent a patient off to CT because it was like the third one down, one of the pupils was different. This person didn't get a full report in the morning, and there was nothing wrong with that patient. That patient had that enlarged pupil from an accident that they had, you know, like 40 years prior. So kind of important to know what the status is. This one, I hope you can hear it. Let me just see. Our Glasgow Coma Scale is also something that might be a free response question where you'll get a scenario. So a Glasgow Coma Scale, it's going to give you the status of your patient. So tell me if you can hear this. Could you hear that? Anybody, can you hear that speaking?
No, we can't hear it.
All right, well, it's really quite a bummer because well, you can listen to it after, but I'm going to do one more thing and see if I can go to settings. I'm having so much trouble with this, but I'm still not complaining because I don't want to have to bring everybody back into class for silly videos that you can watch at home. But a Glasgow Coma Scale is what you'll be measuring, and you'll hear, like if you work in the ER, what is the GCS? It's a Glasgow Coma Scale. They're used for if there's any level of consciousness changes, intracranial pressure, brain trauma, or a cardiovascular accident. So these you watch out for these symptoms: a headache, nausea, vomiting, poor pupil response. And I'm going to go through, wait, 1 second.
Linda, did you mean cerebral vascular accident?
Yes, what did I say?
Cardiovascular.
CVA. Oh, sorry. Yeah, it's a CVA, a stroke. Could be an ischemic, could be a hemorrhagic, but it's a stroke. And I can't get this to work. Gosh, I'm just having technical difficulties. It took me 45 minutes this morning to get this up and running to where you could hear me speaking and the actual screen was sharing. So I would like you to see this, So I'm going to give you 15-minute break, and I want you to pull it up on your screen and watch it so we can talk about it. We have advanced neuro assessments for posturing, and this is an important one to remember because decorticate and decerebrate are problems with the cervical spine or cerebral hemisphere, or then problems with the midbrain and pons. And I know if you've seen any patients with these conditions where they are flexing in or they're extending out, they've had an assault to either their spine or their cerebral hemisphere, midbrain, or their pons. And these are just two like examples. And I show them this to you in peds as well. Advanced neuro assessments for breathing. When there has been an assault to the brain or a changing condition, you're going to see the different types of breathing. Change stoking is something that you'll probably hear in end of life breathing if you have a patient that is, on comfort care and actively dying, you'll hear that. And then there's the central neurogenic hyperventilation, a few stick breathing. It's very hard for me to say. It's a prolonged inspiratory phase or pauses alternating with expiratory. And when you put a patient on a monitor, it doesn't just measure their O2 saturation, it shows you the rhythm of their breathing. And when we do that in the CCU, we connect them and we're looking at it and they'll say it's not connected right. We're not getting a read. And sometimes it is because they are having a cluster breathing or an ataxic breathing to where you see a different dip in their breathing. So it could be a number of many different things. And again, I would like you to listen to this. The one that sits well and sits, kind of sits out for me is the chain stoking. So if you are part of a patient that is actively dying, you will hear that, and you'll hear like a hard breathe, or almost like a snore of inhalation, and then an exhale, and then there'll be a lull. And then another like high inspiratory with maybe like a snore sound to it, and then another lull. And it goes on for a while, and it's very distinct. Testing for the different neurological diagnostic testing, of course, are the MRI and a CT scan. They have the cerebral angiogram and EEG, the brain tissue oxygenation. And in the unit, you'll see patients that are put on the ICP insertion or the Lycox catheter, and that's what you're looking at right there. And you'll get more of that in semester 4 when you do critical care. But sometimes they come up from step down to surgical trauma or to 1RT with an ICP in still. It just depends. Components of the brain, and if you think about the brain, you're looking at this neurosection. Cerebral spinal fluid 10%, intravascular blood is 12%, and brain, mostly brain tissue. So there isn't a whole lot of circulation. It's a lot, it is a very vascular part of your body, your brain tissue, but it's also not a lot. It looks like it's, a lot. And if there's a brain bleed, or if somebody hits their head or something and it bleeds a whole lot, it really isn't a lot in comparison to the rest of the body. Intracranial pressure inside the skull, including the pressure between brain tissue, vasculature, and cerebral spinal fluid. Normal ICP is 7 to 15. The only way to measure that is with an intracranial pressure monitor placed inside your brain. Greater than 20 needs to be monitored and treated, meaning that if there is that much pressure, they may have to put burr holes in to relieve that pressure if there's a bleed that's actively happening. Here you'll see for an infant less than 7.5, and you will, if you go to the NICU, if you have that opportunity when you're in peds, everybody likes the NICU rotation the best. The very premature babies will be monitored very closely for their intracranial pressure, because it's very hard for them to keep their hemodynamics and keep their pressure without having, cerebral hemorrhages. So that's monitored very closely for those, especially the premature infants, children less than 10, and of course, adults less than 15. So you're definitely, if it's greater than 15, they're going to be monitored. They're going to be, probably the intervention is going to be burr holes, so where they let the pressure out and they have that monitor inserted in the brain to measure at all times what that pressure is going to be. Could be a lesion, could be edema, could be a hemorrhage or stroke, hypertension, a head injury, inflammation like caused virally or, you know, bacterially, and then a metabolic insult, like it could be a thyroid emergency, it could be a diabetic emergency, that type of thing. Increased cranial pressure signs and symptoms. You have a change in your level of consciousness, papilledema for your eyes, posturing, like those pictures that I showed you, decerebrate or decorticate, or they're just flaccid and limp. Changes in the vital signs. So an increased systolic pressure with a decreased pulse. And that would be the Cushing's triad, like irregular respiratory rate, a vomiting not preceded by nausea. It's just like it could just be a projectile vomiting. Changes in your speech, decreased motor function for sure, in the posturing. And then for an infant, you would notice that there's a bulging fontanelle. The cranial sutures that have already been fused are starting to separate, an increase in the circumference of the head, and then a cry that's not normal, a high-pitched cry. And they really do monitor that in the pediatric intensive care and in the NICU when this is something that is on the table for them. Like if they're not able to hold their blood pressures, their hemodynamics are off, they're always monitoring the intracranial pressure because they don't want any cerebral bleeds, which could cause, you know, severe brain damage. Monitoring, there are the different types of ICP monitoring, but this is just a basic one where it goes right in to the area that is producing the fluid, and it's a closed cerebral spinal fluid drainage system. It's going right into the ventricle. There's also subarachnoid, intraparenchymal, and an epidural. So it can be in various places for various reasons. And you will see that in the critical care rotation. I took students Tuesday to critical care rotation at Cottage, and they did have a patient that had the ICP monitor and it wasn't stable at that time. So that student got a lot of information because they were able to, they have to write a paper in 4th semester, all of you guys will, a critical care paper. And she got a lot of information because it was an ICP monitoring patient that was not stable. They couldn't get the pressure regulated. So there is a 3-way stopcock to where they will release fluid or they will stop it and see if they can sustain the fluid. It is pretty confusing, but it's in critical care and you'll get a lot more of that. They do Q1 hour neurochecks or Q15 minute neurochecks really, but priority is the oxygen level. The head of the bed is always above 30 degrees. And the head in a neutral position, meaning probably looking forward straight. It says suction only PRN and avoid if possible because that can stimulate the intracranial pressure. You monitor for hypothermia because the temperature gauge in the brain is off. And then administer medications like the barbiturates, the opioids, osmotic diuretic or the mannitol to take the fluid away from the brain, and hypertonic saline. The patients, of course, are in critical care, and we do have to know about this because what will be happening is the patients that you will be receiving will have suffered this insult and it will be a step down for them. So let's just say there is a change in condition and something happens. The change of condition would mean they came back to the floor after, you know, maybe the ICP monitor was pulled, and then they had a change in condition, maybe a loss of consciousness. They started slurring their speech. They would immediately have to be reassessed and probably readmitted for an emergent situation. This just shows you the cerebral blood flow, the amount of blood passing through the brain and the tissue is not that much, but it says automatic alteration in diameter of cerebral blood vessels ensures a consistent blood flow to provide adequate cerebral perfusion. So for our purpose too, you can also think of this. Perhaps you're giving a patient a HCTZ, blood pressure medication that has a diuretic in it. And they take it and they go to stand up quickly and their body can't sustain the circulation. They aren't getting enough perfusion to the brain. They can get lightheaded and pass out. So our responsibility would then be to educate these patients on hypertensive medications, diuretics, these kind of things that could kind of interrupt the blood flow to the brain. And that's generally what will happen, and what will be ordered if they do have an episode like that would be you do the blood pressures. Help me out. You would do the sit, standing, orthostatic blood pressures. That would be something to think about when it says cerebral blood flow. Well, how are we measuring that? Well, we can tell by how they're behaving. A normal normal pressure needed to ensure blood flow to the brain is between 60 and 100. And less than 50 may indicate ischemia or neural death. So cerebral perfusion pressure, or CPP, and equals the map and the intracranial pressure. So you want to make sure that when you are doing your assessment, and of course this semester you guys are just getting it together. You guys are getting all your skills in, you're getting everything, but any kind of change in condition.
Is that map minus the intracranial pressure, or map and the intracranial pressure?
Your map minus your ICP.
Okay.
That's your,
Double
yeah.
check.
So hold on one second. Just 1 second, you guys. So yeah, anyway, so your cerebral perfusion pressure is you're going to be your mean arterial pressure minus your intracranial pressure. And it's something, again, that I wouldn't say we're going to be measuring in third semester, even in clinical, but in fourth semester, you're going to be exposed to it. And meaning you're going to be exposed to it is you're going to be 2 days in the, 1 day in the MICU, 1 day in the SICU. And generally, regardless of what type of patient it is, that is going to be monitored. They always go by a mean arterial pressure. And if it is a neuro patient, you're going to have an intracranial pressure to read as well. Head injuries and skull fractures, those are pretty brutal, but you see battle signs and raccoon eyes for somebody maybe that got hit head on. Those are kind of rough. I will show you. Head injuries or hematomas, and you see here unconscious to lucid to decreased level of consciousness here when you see that there is a hematoma. Epidural hematoma versus a subdural hematoma. Sub, you see here slowly expanding with the venous blood, and here you see rapidly expanding with arterial blood. When you're thinking of a patient with a hematoma, like, I know, has anybody gotten a goose egg before? I hit my head so hard in the glass door that I had a huge size of a golf ball. But I also had a subdural hematoma, a subarachnoid, where you look down further here. I had a hemorrhage and I had to have brain surgery. And it just came on instantly. I got myself to the hospital instantly. I had the intracranial pressure monitor in my brain, and I should have bought the farm, but I didn't. So I don't take too many things too seriously, but it was an emergent situation, and I was in the ICU, and I did have to get rushed there and all that mess. And they open up your brain. Now they go through your groin. They coil those kind of hemorrhages. Back then it was in 1998. And they cut my head wide open right on the side, put the clipped the artery that was bleeding, and sewed me back up. There was an ICP monitor in my head, I think, for 3 days, 2 or 3 days. But if you got on the phone or if you laughed or you talked, it would go up. So they tried to keep you quiet and still. It was kind of a scary time, but it passed. It was just one of those things that I studied more when I was in nursing school, because my mother had one as well with her last child. So these are the kind of things that you're going to see. And my student on Tuesday had one that had a subarachnoid hemorrhage, but she lost consciousness. I never lost consciousness when I started bleeding, and they were trying to help her speak. She became aphasic and she was, and the prognosis for her was very good. And when I walked through the students all, I remember you telling us you had the same thing. I said, I did. And so the nurse brought me in and we talked for a little while to the patient, and you could see where she was slightly coherent. And that was from the subarachnoid hemorrhage. Epidural hematoma, these kind, and subdural hematoma happen quite often to motor vehicle accident patients or to sports people that play very aggressive sports like football. You'll see sometimes that happens. Skateboarding accidents, bicycle accidents, that happens too. That's why a helmet is so important. The Brudinski's and the Koenig signs show you different injuries that you'll see in different areas of the brain. It says, look up what these signs indicate and what nursing interventions are appropriate. And we will discuss that in peds as well, but I'd like you to see that part, see that section. For us, I'm just quickly going to go over your neuro assessment. You need to be able to do a neuro assessment on all your patients. I know you went over that in semester 2, but you're probably not, you probably think that it's just for a patient on 1RT. It's for all patients. Cranial nerves, again, you go over each one of those and you tell me what each one is for. I wish I could show you these, but just because we have a little bit of time. And then the ICP management, intracranial pressure can only be measured when the catheter is inserted and you're able to monitor that closely, and that's in the units. Sometimes they will go to step down units. Patients do go to step down units with an ICP monitor. I know at Cottage on 1RT, they do sometimes have ventilated patients that go downstairs that are long-term, that live on their ventilators, but not usually. And ICP monitors don't usually go down to step down monitors to step down floors at Cottage, but they do in other hospitals. Brain injury interventions are taken for a traumatic brain injury patient. There are a lot of, there are a lot of different, not rules set out for them, but there are a lot of different guidelines for these patients. They can become very combative. They can become very sporadic, erratic. They can change their personality or their behavior, their level of consciousness very easily. It could have been the most calm person that you'd ever want to meet, and all of a sudden they are fighting, hitting, biting, kicking. They need security there. It's really kind of one of the hardest things for family members to deal with. And I do know that it has happened to students to where they're afraid to go back into the room. They don't want to take care of these patients because it's scary. It is scary. Sometimes these patients are, I don't want to say they are generally hard to take care of, I think, but it's also one of those things where you're going to have to take care of them. You will have them. A lot of times it's the atmosphere that can help to not pretty much de-escalate or keep a patient at a normal level, meaning that if it's not as bright in the room, if you have the dimmer lights in the room, if you keep things quiet, they tend to keep the brain injury patients close to the nurse's station, which is kind of a double-edged sword. You want to keep an eye on them, but also there is a lot of interaction and movement at the nurse's station, which can be very, it can be very distracting for these patients and cause episodes of, combativeness or screaming rage and all that kind of stuff. Or they can become very somnolent. They can become very quiet. They can become non-responsive, so to speak. So that also too is one of the harder things for patients, for nursing staff to have to deal with. And it isn't easy. I know this because I have taken care of traumatic brain injury patients, and it's not easy for anybody involved, but it is a good experience for you guys if you get the opportunity. So there is that, I don't know. that opportunity. I guess that's what it is. It's a good experience is what I want to say. I'm trying to get your second section up here. Am I sharing neuro part 2 chronic neurological problems with you right
No.
now?
We're
Okay.
we're just seeing you.
Click around. Can you see me click around at all or not?
Oh, we just see your profile photo.
Okay. All right. Window. Now I'm trying my best here, guys. How's that? Neuro part 2?
It says you've started screen sharing, but it's just black. There we go. Neuro part 2.
Okay, chronic neurological problems and more stuff. The patients that you take care of, like I was saying, it is a good experience. It's a good experience to get in there and get a patient that has had a traumatic brain injury. And usually, in 1RT, the ones that I've seen, the patients that I've seen and experienced would be not just the stroke patients or not just a motor vehicle accident, but a lot of times it could also be patients that have been beaten or assaulted. And it's hard to find placement because generally the homeless population, when they get in fights and there is a traumatic brain injury, it's hard to place them because, again, there's not many places that will take somebody that they know it's going to be a very high acuity. So you'll get these chronic patients. You'll get these patients on 1RT, and it's difficult. It is very difficult to find placement. So you'll kind of get passed around. And at that point, they're happy to see students because students can help. And you kind of get attached to these patients. They're just like residents on the floor. A couple of semesters ago, we had 2 semesters straight with the same guy on 1RT, and he was in the first room, and everybody in the hospital knew him. But he was a brain injury patient, and placement was very difficult. He finally did get a place to go for brain injuries someplace in Los Angeles. That was after, like, I think he was almost on 1RT for a full year. So there's those patients that you're going to get acquainted with if you're on 1RT. And for semester 3, I don't know if many of you are on 1RT. I'm not sure. Multiple sclerosis, a neurological condition. It usually affects young to middle-aged adults, onset 20 to 50, and women more so than men. It caught a chronic autoimmune inflammatory neurological disease of the central nervous system. And it does cause the inflammation and scar tissue or lesions, and the immune system is mistakenly attacks myelin sheaths, the myelin sheaths, and I'll show you a picture of that in a minute. But usually they're smooth, tubular, and this has cracks in it, which causes like an interruption to many different things. They experience dizziness, they get vertigo, lightheaded, feeling of off balance. Their room's always spinning. I mean, it's really a scary thing for somebody to have this a rapid onset. They get the numbness and tingling. They have pains and burning like a myasthenia gravis or like a what is that, fibromyalgia, that type of feeling. And oftentimes women get misdiagnosed with MS. Problems with the vision, difficulty walking. So different things like this. Let's say it's closer to the age of 50. A lot of women are misdiagnosed because they equate this with just getting older. The cause is unknown. Infectious, it could be related to an infection, and immunologic or genetic factors. It says multiple genes confer susceptibility to MS. So chronic inflammation, demyelination of those myelin sheaths, gliosis in the central nervous system, primary neuropathologic condition. It's an autoimmune disease orchestrated by the autoreactive T cells. So there can be different kind of treatments that they'll do, try to maybe feign things off. T cells migrate to central nervous system, causing the blood-brain disruption. So making a patient foggy, making them feel like dizziness, fogginess, like maybe like a mild flu-like symptom, subsequent antibody reaction leads to the demyelination of those axons, I think. Oh, here's the picture. So if you see the nerve fiber and the node of Ranvier, they look normal. You'll see a smooth, round, tubular, and then as it starts to demyelinate, you'll see the cracks and pretty much where they're unable to make the connection. And when that happens, like there's a whole breakdown in the system, the damage is there, and it's very difficult for motor functions, for just any like simple movement. It's painful, and it also can become very paralyzing. So this picture is the perfect picture to get in your head of what's going on. The medications that are given, we'll talk about the medications in just a minute. This just shows you here chronic multiple sclerosis and the gray to white junction. Here you'll see like, just this funny, weird, filmy stuff. But how would you know what a normal would look like? It's just kind of trying to explain that. But autoimmune, usually for female, it's familial. The tinnitus in the hearing is one that most MS patients will say is their worst symptom. It can make somebody go crazy. It can make people want to commit suicide because it's so assaulting and it's constant. The nystagmus, diplopia, blurred vision, dysarthria or dysphagia, those kind of things too, of course, are not fun to have. But urinary retention, a spastic bladder, constipation, weakness, progressive paralysis, muscle spasticity, all of these things are symptoms, but the one that chimes most to these patients in the beginning is the tinnitus. Some people overcome it and get used to it. They get used to hearing this, ringing in their ear, this constant ringing, but it also can be very assaulting. It can just be like something that makes them want to, not live anymore. It's chronic, progressive deterioration in some. Some can have it for a long time and remiss. So have little spurts of exacerbations, meaning the symptoms show up and then they remiss for a while and they keep kind of like a level of homeostasis for a while. Bowel and bladder functions can be impaired. It's a spastic bladder. So you have the bladder, which is transitional epithelium. So it, expands and goes down after you empty it. It kind of is something that you train as a 2-year-old in your brain. Oh, I'm going to hold my urine. Okay, I'm going to go to the bathroom, that kind of thing. You start at a very young age. Well, a spastic bladder is something that is very erratic. It can be, I have to pee right now. I just lost my bladder right now, just sitting here. Or it could be a flaccid bladder, meaning that it doesn't have that epithelium. That epithelium is not transitional. It's not functioning and contracting the way it should. So it's just kind of filling up and it can rupture. So sometimes these patients are self-catheterizing themselves to empty their bladder because they figure at this time, and this time, that will keep things at a normal rate. So a large capacity for urine with no sensation whatsoever to urinate. They have a sexual dysfunction. The cerebral manifestations, again, the ataxia, dysarthria, dysphagia, nystagmus, that's all something that could be very difficult to live with in as far as not being able to see right. It gets you very dizzy. But again, I always hear that the ringing in the ear and the dizziness is something that just doesn't let up. It doesn't give you any chance to have a break, so to speak. So you're thinking all the time, you've got this awful feeling, this awful sound going on. It's a ringing, and it's just something that, I don't know, I feel like that would probably drive me crazy too. But then you go through sensory. The Lermit sign is and like an electric shock sensation. It happens when you flex your neck. There's the numbness, tingling, blurred vision, vertigo, and tinnitus is probably the most annoying of all of them. And then the chronic neuropathic pain. So you'd feel that in your extremities and sometimes along the base of your neck, you'd feel that pain. Cognitive wise, short-term memory attention. Processing the information is a difficult one too for somebody that's, out in the world, maybe working in a very high stress job, and then all of a sudden they're getting information thrown at them like they have forever, and it's just not computing. And they show up the healthcare provider and say, all of a sudden I'm unable to understand what people are telling me, and my job is suffering by this. And that's when further investigation sometimes brings up this multiple sclerosis condition or diagnosis. Planning, you have a difficult time planning your day, like you guys. I'm going to get up, I'm going to take that test, I'm going to listen to this blah blah blah, and then we'll do one more thing and we'll be free for the day. I'll be able to get XYZ done. Well, a person that's having this cognitive interruption is like, I know I have to get up, but now I'm not sure exactly what I'm going to be doing after this, or what am I supposed to be doing, that kind of thing. Visual perception. Patients that have not yet been diagnosed will sometimes have a visual perception to where they're walking and they're not kind of gating where they're going. They can't see where they're going. There's a lot of falls because they thought they had one more step. So there's that visual perception. And then finding words. One woman said, "You have very big, beautiful brown braces." Okay, so the girl was wearing braces, but she had big eyes. You just can't, you're going to say kind of what you think, or maybe not what you think. The words aren't coming out where they're supposed to come out. The one thing for us as clinicians to deal with are the emotional manifestations, especially for a newly diagnosed patient with MS. The newly diagnosed, they're going through so many things. So going back to sensory, the alarmants, they're getting that electric shock sensation in their neck. They're thinking, I'm so stressed out. I've got this ringing in my ear. I'm not sure why. They're getting all these things building up, building up. Well, all of these sensory and cognitive things that are kind of building up are causing frustration. You can't find the words. You're not able to plan. Somebody's giving you 15 things to think about and you're not processing it well. Well, it's going to definitely migrate to emotional manifestations. You're going to get angry. You're going to get depressed. This euphoria is a different one, a kind of more difficult to explain or to understand, but you have all these different emotions that you don't know what to do with. And again, in the beginning of one of these diagnoses, it's hard to put together where you are, what's going on, and then trying to look to the future. You're thinking, how am I going to maneuver through life with this? You do become angry. They get very depressed. All those emotions kind of come to play. And this over off to the side to the right, you'll see just the different main symptoms of this condition. And again, there is no cure. It's an unknown where it came from or why people have it. And I think just keeping it, under control is pretty much what most patients hope for. Based primarily on history, clinical manifestations, and the presence of the lesions over time. Those are checked by MRI. They check with a lumbar puncture. And if you're ever able to sit in and watch the lumbar punctures, they're pretty interesting to watch. And you'll see the cerebral spinal fluid just drip out, and that gets tested for many different things. It could be clear, cloudy. They check for the appearance, WBCs, glucose and protein, bacteria or viral. It could be either one of those things when you're checking for a lumbar puncture. They check a lot of different things with that, but it is an interesting procedure to watch and to be part of, and it's where you can be diagnosed. Let's see. The collaborative care, you're going to have a lot of, there are not just for drug therapy, but collaborative care would mean you're going to have a social worker, you're going to have a dietitian, you're going to have a physical therapist, you're going to have occupational therapy. Sometimes speech therapy will get involved as well, but the drug therapy is usually the corticosteroids, which are kind of saved up, like I always tell you, for all these different conditions. to reduce edema and inflammation, where the myelin sheets are demyelinating, and they aren't used all the time. And it says that they do not affect the ultimate outcome, but it does help with the exacerbation. So usually patients like this might be on a very, very low dose and get it upped when they have an exacerbation, or they're not on the meds and then they get put back on, built up, and then weaned off that. They do the immuno modulators, interferon B, 1B, interferon B1A. They do the Copaxone, and that's glatimer, glatamer. It's hard to say. Copaxone is easier, and Tysabri is easier than these other big words. But this is just like a cocktail. Some patients take some of these, some take few, or some take more than this. But the one that kind of rings for me and for students is the corticosteroid. So make sure that there's plenty of teaching going on and that they know not to just stop it abruptly. It is like one of those kind of medications that a lot of times patients think they know about it, but they don't. They don't know exactly what the repercussions are if you stop them abruptly. Take 10, you guys, and I'll see you back here for different medications. Thanks.
Sorry, Linda, did you want us to take 15? And
Oh,
we'll-
if you want, yeah, that's a better idea. I'm sorry, you're right, because I want you to look at that Glasgow Coma Scale so we could chat about it.
Okay.
Thanks,
Thank-
guys. And that you're going to need to know how to do that. The beta interferon medications are used. It just gives you, you know, a brief little scenario so you can see the different names that you might come in contact with when you have an MS patient. So go ahead and look at those. It says collaborative care and other drug therapies. They do muscle relaxants, the CNS stimulants, anticholinergic. So you'll see over here, Solumedrol, Decadron, Deltazone, and the IVIG. The IVIG I do for a lady every other month. She gets her IVIG and she has MS. So, I mean, there can be like treatments that go over a long length of time. I've been doing her treatment for about a year and 2 months now. I don't know how long she had it before I started working there, but it seems to, you know, help her. It says for those allergic to or intolerant to steroids, she can't take steroids. I know that. And here's just some more different medications like these muscle relaxants that help with the spasticity, but also too, the other side of that is they can become very flaccid, unable to move, that kind of thing. So they don't want to over medicate with the muscle relaxants. Antioxylytics like the diazepam, those kind of medications are used. Collaborative care, when I was talking about, would be, this is physical therapy. Surgery can also help. They do that dorsal column electrical stimulation to where they have like a little handheld pump where they are able to stimulate the area when they're feeling numb. Intrathecal baclofen pump, that's the muscle relaxant that will help when they have spasms. And then, of course, physical therapy. And this is usually towards during an exacerbation or after a really long, hard exacerbation where they're just trying to get back to a little bit of use. Nutritional care, I said that there would probably be a dietitian involved. It includes mega vitamins and diets consistent in low fat, gluten-free foods and raw vegetables. High protein diet with supplements are always often prescribed. So not anything fun or exciting for them. Parkinson's is another condition. So that was all MS. But when we talk about Parkinson's, usually a gradual onset after the age of 50. We know younger people that have, you know, have this condition, and the onset is rapid, and it's usually in males, but, you know, females, of course, get it too. They have a mask-like blank expression, which is really kind of, I don't want to say scary, but it's alarming. It's uncomfortable because when you speak to a patient or you go in and address a patient, introduce yourself and everything, when somebody's looking at you with that blank stare, it's, it's uncomfortable and they don't have that muscle posture to be able to change the way they look at you. And it's really, sometimes after the medications have been taken during the day, that can kind of ease up a little bit. They still have that stooped posture, pin rolling tremors where their hands are moving and shaking. They have the tremor, bradykinesia. So it says loss of normal swing in their walk. They have kind of like a shuffling gait, and they get very stiff. It's really difficult for maybe them to sit. You'll see them kind of plop down and they're still shaking. Or you could see a person that has been, maybe sitting for any length of time, then all of a sudden start to get a tremor when it goes into a full blown like spastic episode where their muscles are moving, they're shaking and they're stiffening and they're doing this whole big thing. And it's really hard on the patient because it's very embarrassing for them, but also it's very nerve-wracking for a caregiver or a partner to be with the patient when they have one of these episodes. When they're walking, you'll see a forward tilt of the trunk, reduced arm swinging. They're kind of rigid. The head is trembling. And you can also notice too, now thinking patients that have that slight tremor, you'll know that, oh, it's probably, the early signs, or they have Parkinson's. They take the Cinemet, Parladel, Symetrol, Cogentin. These are just some of the meds. It says here, comparison of drugs used to treat Parkinson's disease, and you'll look at all the different meds. There's the dopamine agonists. Those are the ones usually used. And then here, dopaminergic. So carbidopa, levodopa, those are meds. And oftentimes what happens is in the morning, you go in, you assess your patient, and let's say the meds are ordered for 8 o'clock. A patient might request, I take my meds at 9:30, 10 o'clock. Can you please come back? Discuss it with your instructor and your primary nurse. They don't take their meds until this time. Can we please change the time on those? You wouldn't change them, but they could change them. And then you'll see that once the meds start getting taken, like different muscle structures are affected and they're able to kind of function a little bit better, like unwind, or the rigidity is kind of softened and they're able to sit up, maybe eat their meal, have a little bit of a conversation. And that's kind of like how a lot of these patients start their day. It says anti-Parkinsonian meds, dopamine replacement is usually the main one. So the carbidopa, levodopa you'll be giving. And it's, there is no cure. A lot of the patients just want to have like the best ADLs, like activity of daily living. They want to be able to get up, go to the bathroom, toilet themselves, wash up, maybe eat breakfast, sit down for a while before they have to go back down for a rest, those kind of things when they're in the hospital. So it's part of your, plan of care for them is to wait until their meds are kind of starting, the levodopa is starting to work before you try to incorporate, different things that you have planned for the morning for the patient. Like, I'm not talking about taking them out of the unit or anything, but I'm talking about just like, as far as like maybe they've been requested to walk around the unit once. Well, you want to wait and kind of get that window of opportunity when arises when the meds are working just a little bit better. So it's just kind of one of those things where you have to really work with what the patient says. If it's hard for the patient to communicate or they're very advanced in this condition, then you kind of have to wing it and see how things go. I mean, you never know. And oftentimes if there's a caregiver, they can kind of explain, well, if the patient gets their meds at this time, they'll behave this way, or it's easier to get them up, or it's easier to get them in the shower, that kind of thing. So, you have to work close with these patients. We have the myasthenia gravis. So it says peak signs in myasthenia gravis during sustained forced eyelid closure. He is unable to bury his eyelashes left. And then after 30 seconds, he is unable to keep his lids fully closed. So this is just a picture of a guy with myasthenia gravis. This condition, let's see, I can't play that. an autoimmune disorder affecting the neuromuscular transmission of voluntary muscles. It attacks the acetylcholine receptors, fluctuating weakness. Sometimes they are very high functioning and other times they are flat on their back. It just depends. It's highly variable, it says here. There's the different types here. You see diagnosing it, different ways of diagnosing it and different ways of treating it. It says here, exacerbation, early to rise. So early, have patient do activities early in the day. Tessalon is given in case of a crisis. Observe for PT3, DMT, D5, DM5T, you rest. That's just, I don't even know what that is. I don't even know what that stands for. You rest. So it says Tori, rest, provide periods of rest. That could be you want to give the medications for the, especially if there's a crisis. Not enough med is a crisis. So if you don't get, that is a form of a medication, I should say. And if it's decreased, sometimes the patient has an exacerbation. This is a pretty confusing map, but always watch for airway and secretions. Some of the treatments, they do a plasmapheresis, and they have done that. They do the IVIG, so for the antibodies, and then they'll do other different like chemotherapies for a cholinergic crisis. It says too much meds, too much sludge. That's also very confusing, but this picture is confusing, but it kind of gives you the cause, the labs, the symptoms, and the treatment. So that's why it's up here. It says too much, everything's increased. So saliva, like drooling, urine's increased, diarrhea, pain, abdominal cramping. Not enough would be bradycardia. Atropine is given, blood pressure is decreased, and edrophonium give to see if symptoms get worse. So I kind of just look at this with a grain of salt and look to more of the concrete stuff because this is pretty confusing. But for the myasthenia gravis, for the patient's fluctuating weakness and antibodies attack the acetylcholine receptors, they do an EMG and the Tessalon tests. The anticholinesterase and the corticosteroids, along with immunosuppressants, are something that will keep them like at bay or kind of try to level them off, bring them back to a closer level of homeostasis. And then there's the surgical therapy where they remove the thymus. Plasmapheresis is done in the at the cancer center Ridley Tree, but it's also done in the radiation center here at Cottage. We have a plasmapheresis where the patient gets hooked up. It's almost like a dialysis machine, but it's really a complicated machine. And they do this treatment. Something really interesting to watch. I've seen it at the bedside in the ICU. It's a really big and very, very expensive treatment. And they do that to kind of feign off some of those symptoms of the myasthenia gravis. That guy was hard to watch. ALS or Lou Gehrig's disease, a rare progressive. These are all neurological conditions that you might not necessarily have a patient newly diagnosed with this in the hospital, but you might have a patient with a different condition that has this condition already. They may come in for a hip replacement, or they may come in for, an infection or a virus, something like that, and they do already have these. So these are kind of things just to be aware of. The ALS is a rare progressive disease, loss of motor neurons and control of voluntary muscles. They get weakness, dysarthria, dysphasia, and dyspnea. It is 100% fatal. It is it's really a debilitating disease. Some people live very long with it and others not so much. It's facts about ALS. It just says here 5,000 people are diagnosed per year. 10% of the cases are familial. 2 to 5 years is the expectancy. 90% of the cases are sporadic without any family history. It says every 90 minutes somebody's diagnosed, but the one thing is oftentimes, here, military veterans are 2 times as likely to get ALS. That is an interesting fact. It says there are 0 effective treatments for ALS. So the symptoms speak, swallow, walk, grasp objects, move or breathe are all progressively muscle related. And as soon as those muscles are gone, you're unable, a lot of these patients are on vents, but their brain is still intact. And that to me is the hardest one. My friend's father had it for a long time. There's no cure. They do the Riluzole or the Rilutux. It's slow progression, symptomatic treatment. They do treat symptoms, of course, but this says it inhibits the glutamate release. So to kind of keep an exacerbation slowed down or at bay for a short period of time. It says respiratory failure or pneumonia is a great risk and a cause for death within 3 to 5 years. And the ALS, or the amyotrophic lateral sclerosis, it says every day an average of 15 people are newly diagnosed. What's causing it? They have no idea. What is there a cure? There is no cure. I mean, millions and millions of dollars are put into research for ALS. And you often see when someone dies of ALS that they are, say, please donate to, and there's different ALS agencies that just do research on that. It's really a very scary condition because there's no cure. Nutrition or registered dietitian can help ensure that a person's receiving enough nutrients. Physical therapy and occupational therapy can kind of help them with their maximum of independence. They can help them, move as much as they can. Speech therapists are highly used with patients with ALS because after that, it's difficult to communicate only because if they can't speak and they can't use their hands to write, it's really hard. They can't sign. So they can't communicate. And then it says healthcare professionals may recommend a BiPAP machine, which is also something that would help them while they sleep, and even during the day if they're unable to keep their respirations or able to breathe without becoming, hypoxic. This is an older one from 2014. Of course, 115 million. There was much more raised. And this one goes from 2014 to 2019, just kind of before the COVID hit. But they were doing that ice bucket challenge and seeing how much money could be raised. And they did raise a lot of money with that. I don't know that I'd want to do that. I'd rather just donate a little and try not to do that. But people were really, there's a lot of awareness out there. There's a lot of people that are trying to help, and it's a pretty scary condition. And when it hits the family, not only are you taking care of that patient, but you're giving that family a respite as well, because there are some facilities in town that are local and a few more down south that will house your patient for a weekend to give the family or the caregivers a respite, that kind of thing. And it's really important because caregiver burnout is huge. And when you're with somebody 24 hours a day, 7 days a week, it's really something that can wear on anybody. I mean, people are human, and it's really hard to it's hard to do that for somebody as much as you love somebody or you care for somebody, and taking turns. Sometimes if it's a bigger family, they take turns, but still sometimes it's one caregiver. So those respite places are really a life-saving thing for everybody involved. Huntington's disease is another one. It's an inherited disorder caused by death of brain cells, first detailed in 1872 by George Huntington. Onset symptoms between the age of 30 and 50 years old. It says risk factors includes a positive family history, and then here for symptoms: mood altercation, gait abnormalities, jerky movement. So again, it kind of could look like Parkinsonians. Sometimes they're confused with Parkinson's. It's diagnosed by physical tests and gene studies. There is no curative treatment. Symptoms managed by supportive and nursing care. So, complications include mental and physical disability. And that's the one that I would say there's a lot of mental symptoms that come up. Death occurs 15 to 20 years from the time of diagnosis. That's a long time to have that. It's an autosomal dominant disorder. Offspring have 50% risk of inheriting it between 30 and 50 years of age. Deficiency in the neurotransmitter or the GABA. And it's really like cognition, executive functioning, like tasking, problem solving, all of that, memory and learning, attention and concentration, all of these things. I mean, you need all of these things: perseverance, insight, judgment, awareness, adaptability, communication to survive. Your cognition is completely thrown off. Emotional behavior, discontrol would mean you can't control your anxiety, your anger, apathy, depression. A discontrol, disinhibition, you have no inhibitions. You're irritable, impulsive, obsessive, compulsions and psychosis. And those are treated sometimes with antipsychotics, but oftentimes not much result comes from those medications. And then, of course, your motor, your balance, you're not coordinated, you're unable to walk, rigidity, just ADLs, your inability to do any of them, speech, choking, all of that. So it's really another one that's just a pretty horrible neurologic condition to come under. Abnormal excessive involuntary movements, twisting movements of the face, limbs, and body. I did see one short video of a person that was severely afflicted with Huntington's disease. And the family this was before cannabis was legal, and gave them some oil, some cannabis oil. And the patient started to kind of, like, the writhing, twisting movement started to kind of go back from it, unwind from it, and wasn't as rigid, and was kind of peaceful for short periods of time. And they went on to do more research and bring it up to the doctors. And this patient with Huntington's disease was able to use cannabis and be more comfortable. It did not cure that, but it did help with the symptoms. And here you see fidgetity, uncoordination, involuntary movements, difficulty with speech and swallowing, and balance. This patient that was lying there writhing with this, awful movement, was able to lie and rest, and then actually sit up and maybe not communicate so well. I can't remember exactly what the end of that short video that I watched was, but it did help. So who's to say, that might not come on the forefront and help people a little bit more. They have the problems with short-term memory, trouble organizing and concentrating, and just difficulty coping. So that would probably be when it's more advanced. But I do think that gentleman really did benefit from that cannabis, and it was oil, drops of oil in the mouth, and it kind of just slowed down that movement. And I don't know, whatever works, right? So disease progression, speech, chewing, swallowing are affected. A lot of them have feeding tubes. Gait, a lot of them in wheelchairs. Mental function in decline. Emotional lability, they're kind of like cut off, just kind of non-participatory. And then the psychotic behavior too can be really difficult and scary for caregivers. And it says death 10 to 20 years after the onset of the symptoms. So there's the early stage, middle stage, and late stages. And 10 to 20 years is a long time to have to battle something like that. So I would definitely say it takes a lot of courage. Nursing management and collaborative care, it's all of these things. So it's not just the nursing. There's no cure. So of course there would be palliative care. Antipsychotics, because they can become very psychotic, antidepressant, then the anti-chorea medications. It says for our nursing purpose, provide the most comfortable environment for the patient and the family. I mean, that can't always be easy. I mean, we can medicate the patients, we can, help the family get a little bit of respite, but that isn't always, if somebody is in that kind of a state, it's not always easy. The genetic counselors can be more for the family, for the children, so that they know about, perhaps what the future could look like. Physical safety is very important, because they're sporadic. They move quickly. They move without thinking. So there's just a lot of things that come into play with collaborative care. So they have the family, of course, would hopefully be the main key players, but physical therapy, occupational therapy. We have neurologists, psychiatrists, geneticists, social workers, home health nurses, palliative care. The technology would mean like more like if perhaps maybe only they could use their thumb, there would be some kind of technology where they could use an iPad or something like that, or lifts in the home for moving the patient, wheelchairs that move around, that kind of thing. And then of course a nursing home when it's unable to be cared for, a patient is unable to be cared for at home. For Guillain-Barré syndrome, begins in the lower extremities and ascends bilaterally, weakness, ataxia, bilateral paresthesia, progressing to paralysis. That's a scary one too. Risk factors, it could be a possible autoimmune, it could be associated with immunizations, frequently precedes a mild respiratory or intestinal infection, and it can progress over hours to days. Minimal muscle atrophy, symmetrical paralysis. So both feet, it goes up to the arms. And the main thing is when it gets to the lungs, that a tube is, ET tube is placed, endotracheal tube is placed, and the patient is ventilated. So it is an emergent situation where you would need to be in the hospital. Respiratory, talking, swallowing, bowel and bladder function, you just become all, paralyzed, and it could go slowly, but it could also be very quickly. It says acquired acute inflammatory disease of the peripheral nerves resulting in ascending paralysis. So it just comes up, and it's usually after an infection. It could take several months to recover. A good thing is most patients with the right care and therapy do recover with kind of maybe just a small type of residual. So usually develops 1 to 3 weeks after one of those infections. It's usually, not always, weakness of the lower extremities, then numbness, tingling, paralysis, and hypotonia, areflexia, and then pain in the form of muscle cramps and hyperparesthesiasis, worse at night, meaning that you're getting these cramps and this flexion that you can't move like a Charlie horse, like multiplied, rapid onset. And it says it's named after Georges Gillian and Jean Alexandria in 1916. It affects up to 3 per 100,000 people in the US. Most common is acute flaccid paralysis. And then US military personnel are at an increased risk. Affects males 1.5 times more than females. Women at high risk immediately after delivery, after they give birth. So that's kind of a scary one. Symptoms include limb weakness, difficulty swallowing, and shortness of breath. Diagnosed by clinical assessment of blood tests and electromyography. And then the treatment includes immunotherapy and a plasmapheresis, that big gigantic machine again. They're in the hospital. They're getting the whole team that you saw before working with them. EMG, cerebral spinal fluid, drug therapy would be the IVIG, of course, the plasmapheresis if they're able, and then maintain airway. So sometimes they're ventilated, sometimes not, but it could be just like a BiPAP machine. And then the nutritional support, a feeding tube, which is, or not so much an NG tube, but you would see a temporary feeding tube placed. The good thing is that the recovery can happen over 6 months to 2 years, but it says may lead to a long-term reoccurrence of fatigue or exhaustion, abnormal sensation, including pain and muscle aches. But oftentimes the recovery does bring a patient back pretty much to where they were before. So that's kind of a positive for this. Rapid onset, the cause is unknown. There's a few things that they do to check it, like the lumbar puncture or the muscle nerve tests, and then the treatment again. They're in intensive care. They are generally ventilated, but they do the plasmapheresis and the IVIG and hopefully bring a person back. Those are pretty much the tests that we talk about in this section. I'm trying to get this down.
I had
I
a
don't know.
patient and she was diagnosed with Guillain-Barré and yeah, it was like her first onset. She didn't
And-
have a ventilator or anything, but
She wasn't ventilated, and how far advanced did it become?
she wasn't able to move her arms or legs. And then she actually had a fall on my shift when she was working with physical therapy, because I guess the day before she had been able to walk. And then physical therapy tried to get her up and she was like 3 steps out of bed. And like it was just like, it clearly was still progressing even after she'd gotten IVIG, because she was set to discharge to rehab because they thought it, like the exacerbation had ended. And then after that, they're like, okay, well, we need to do more tests to figure out why it's getting worse, even though we've given you the therapy. And like she had been getting like stable in terms of her weakness and the tingling sensations. So
Super scary though.
yeah, it
really
was really,
scary.
her son was at the bedside and there was like a lot of education of like how he was going to have to be a different type of caregiver and like giving resources for just more information to learn about it, because it was like the family had never heard of it.
How old a woman was that?
She was in her 60s. Yeah. She was
In her 60s.
she was in her 60s, and I think for her the biggest thing was she was like, oh, I'm a busybody, like I've never been tired, I've never been weak, I don't know what's going on. And it was like she had just gotten, they thought it was like a COVID, maybe the COVID test was negative, because she was like, oh, I had like a cold, a really bad cold a couple weeks ago. Like I thought the weakness had to do with that. So it's interesting now.
So hers was after an upper respiratory, because they say GI or upper respiratory, and then people just get hit with it. But the one that fascinates me is a woman after giving birth. And I don't know if your system just gets so knocked down that that would be some, I don't know. It's interesting to me. Very interesting. You guys, I am going to break because I'm going to try my best to get out of this Zoom and open up the PED Zoom, just because that's what we should be doing. So I will do my best to meet you guys back here at 11.